left breast. At that time, the lump was almost 2 centimeters in size, and it gradually increased in size to reach the present size of almost 3 centimeters. There is no associated pain, no history of trauma to the breast. No redness of the lump, no ulceration or bleeding from the lump, no nipple retraction or nipple discharge, no fullness or mass in axilla or in the opposite breast, no swellings elsewhere, no associated fever or associated systemic symptoms. Past history. Patient is not a diabetic or hypertensive, no history of coronary artery disease, no history of prior radiation to the chest, no history of prior breast biopsies. Patient attained menarche at 13 years of age. She has regular menstrual cycles. She is married and has 3 children. Her first childbirth was at the age of 25 years. Last childbirth was 8 years ago. She has lactated each child up to 2 years of age. There is no history of use of oral contraceptive pills. She underwent postpartum sterilization 8 years back. Coming to her personal history, she has a non-vegetarian diet, has regular bowel and bladder habits, no history of alcohol use or tobacco use. Family history, no history of malignancy in the family. Then I would like to summarize the history of this patient as a 41-year-old multiparous premenopausal lady with no comorbidities, presenting with a painless left breast lump of 4 months duration, which is gradually progressing in size.
So what are your differentials based on this? A young female, just painless 3 centimeter lump.
Sir, my first differential is a malignancy of the breast, as there was a progression in size of the last 4 months, progression in size of the lump of the last 4 months.
She's just 41 years old. Will you keep malignancies as your first differential?
It's a benign conditions
Of just 4 months, the duration that too.
There are benign conditions like fibroadenoma of the breast is also considered, fibrocystic disease.
Okay. And why did you ask the history of trauma?
Sir, to rule out any traumatic fat necrosis.
Okay, good. Old question.
So may I proceed?
Yeah.
Coming to the examination, general examination. Patient is conscious and cooperative. She has an ECOG performance status of 0. Her height is 160 centimeter and weight is 70 kilogram and BMI is 27. Overweight as per BMI of WHO category and body surface area is 1.76. There is no pallor, icterus.
Why did you say ECOG performance? Why did you say ECOG performance status is 0?
So she's fully active and has all the pre-disease performance status without any restriction of activity.
Okay. And when will you say it as 1?
So when there is restriction of physically strenuous activity, but able to carry out light work.
Okay.
And the patient is ambulatory.
And Dr. Rani, just one question. Like you said, overweight. So what is the relevance of overweight in this patient?
Sir, in postmenopausal obesity is a risk factor for breast cancer, but in premenopausal age group.
Okay, yes. Right. When it comes to treatment and follow-up, this may have some implications, but otherwise, we have strong evidence for postmenopausal obesity associated with breast cancer. All right, proceed.
Coming to the vital signs, her pulse is 84 per minute, regular. Blood pressure is 120 on 70 millimeters of mercury in the right arm, supine position. Respiratory rate is 16 per minute, thoraco-abdominal, and temperature is 98.6 degree Fahrenheit. Local examination. Patient was examined after an implied consent and ensuring adequate privacy. She was examined in sitting with arms on hip, arms above head, and in supine position. On inspection, both breasts are at equal in size and shape, and there is no asymmetry in any quadrant of the breast. The nipple areola complex, both nipple are at equal level. There is no visible discharge, retraction, excoriation, or ulceration. No visible swellings or nodules. No scars, sinuses, dilated veins, erythema, or pudy orange appearance. Bilateral arm, axilla, and supraclavicular fossa appears normal on inspection. Coming to palpation, palpation of the right breast, axilla, and supraclavicular fossa are normal. There is no local rise of temperature or tenderness in the left breast. There is a lump of size 4 by 3 centimeter in the upper outer quadrant of the left breast with smooth surface, irregular borders, and hard consistency, and the lump is free of chest wall, underlying muscle, and overlying skin, and the nipple area complex is normal on palpation. Coming to examination of the left axilla, I felt two discrete nodes of size 1 to 1.5 centimeters each felt in the axilla, which is firm in consistency and is mobile. And bilateral supraclavicular fossa was normal on palpation.
Why did you examine supraclavicular fossa?
Supraclavicular involvement of supraclavicular fossa upstages the if in case of breast cancer, it upstages the malignancy
To
N3C disease.
to N3 disease. And is it ipsilateral or even contralateral? Contralateral will become M1 or no?
Sir, ipsilateral is N3C. Contralateral becomes metastatic, sir.
Sure. Check that.
So may I proceed?
Yeah.
Coming to systemic examination, the other systems are within normal limit. No hepatomegaly, no ascites, no focal neurological deficits, no spinal tenderness, and on pelvic examination, no admixal mass is felt.
Why did you check for skin involvement in systemic in local examination?
So check for
Skin involvement or body orange. What is the significance? How will you change the management? First of all, what is the significance of body orange, and second of all, how will it change your management?
the pure orange appearance is due to the infiltration of the dermal lymphatics. If pure orange appearance is there, then the disease becomes C4D.
So management. Perspective.
It becomes a locally advanced disease and requires neoadjuvant systemic therapy.
Okay. Even for a 4 centimeter tumor will directly become to upstage to T4.
Yes, sir.
Okay. Yeah, proceed.
Coming to the summary after history and examination, 41-year-old multiparous premenopausal lady with no comorbidities with an ECOG performance status of 0 who presented with lump left breast of 4 months duration. On examination, there is a 4 by 3 centimeter lump in the upper outer quadrant of the left breast with ipsilateral axillary lymphadenopathy with no features suggestive of systemic involvement.
What do you feel are lymph nodes on your palpation involved, or what could they be?
So I feel they are significant lymph nodes.
What was the size clinically?
Sir, about 1 to 1.5 centimeter size. Firm nodes, discrete, mobile.
So do you feel they can still be reactive, or they are involved?
So I feel it is involved, but we need to confirm with ultrasound and guided FNA.
So how will you evaluate this patient?
What is the stage?
What are your differential? Sorry, what are your differential and what is your stage if differential is a malignancy? Now after the end of history and examination.
Carcinoma of the breast clinically CT2N1 composite stage of stage 2B.
Okay.
All right.
So how will you evaluate this patient?
So I would like to further investigate the patient for diagnostic workup, staging evaluation, and investigation for fitness for therapy. So I would first proceed with the mammogram of the bilateral breast, followed by a core biopsy from the breast for histology, grading, and IHC for typing ERPR, HER2, and Ki67 index. Also, a guided FNAC from the suspicious axillary lymph nodes. Then, sir, I would proceed with the PET-CT examination. And for
Okay,
fitness,
so mammogram. Yeah. So what are the
sir,
issues in ordering a mammogram for this patient?
she's a young patient, so dense breast.
So it should be like combined ultrasonography plus mammogram.
Yes, sir.
So conventional mammogram will not be
Sufficient.
contributory in this patient.
Sir.
Yeah. Yes.
Mm.
Okay. So
Do you
what do
have
you
photos, images?
No, sir.
Okay.
so what are the findings that are looking for in a mammogram for this patient? What all information it will give?
So it gives the information regarding the size of the tumor and the quadrant of breast involved, multifocality, multicentricity, then microcalcification, also breast density, then axillary lymph node, and if contralateral breast involvement is there, this can be assessed from the mammogram.
All right. Okay. So you have the report or anything?
Yes, sir.
Okay.
The BIRATS 4C to 5 lesion, 3.2 by 2 centimeter, irregular hyperdense lesion, heteroechoic focal mass in left breast 2 to 3 o'clock position. Also multiple enlarged axillary nodes of 1.9 by 0.8 centimeter and 1.6 by 0.8 centimeter. Suspicious metastatic nodes.
Okay. So in a BIRATS 4 lesion, BIRATS 4C lesion, what is the chance of it being a malignancy?
It is a 50 to 95% chance of it being a malignancy.
Okay. All right. Okay. So next.
Then I would do the investigation for fitness, including a complete hemogram, liver function, renal
The
function.
biopsy.
Biopsy.
Yes, sir.
What's the biopsy finding?
So for this patient, the biopsy finding is invasive carcinoma of the breast, grade 2, ER negative, progesterone receptor negative, HER2 3 plus, and Ki67 index is 18%.
Okay.
Go ahead.
We have further evaluated this patient with a PET-CT scan. And in PET-CT, it is a...
So before that, Dr. Annie, so which all patients will you do a staging investigation in breast cancer? What are the recommendations?
and
what is the staging investigation generally?
Sir, in early breast, yes, sir. In early breast cancer, the staging investigations are ultrasound of abdomen and chest X-ray. And in a locally advanced disease, we consider a contrast enhanced CT scan of the thorax, abdomen, and pelvis along with bone scan. However, a PET-CT can also be considered.
Okay. Yeah. So actually, as per the recommendation, early stage breast cancer, staging investigations are not recommended unless there are any symptoms to suggest a systemic involvement or some clues like elevated ALP and all. So that is the recommendation. Practically, as you said, we all do at least ultrasound and X-ray to rule out metastasis. So, so what are the percentages of this patient having a metastasis detected in a bone scan or similar imaging?
Supposedly, this patient did not have a node clinical examination. Then, what was the percentage of this being a metastatic disease?
Around 5 to 10%.
Okay, 5% roughly. That is why
5%.
we don't
Yes.
do a systemic staging for such patients. If it was node negative clinically, or now that it is HER2 positive, for aggressive biology disease, maybe you can keep a low threshold and do a scan. Is what ESMO recommends. Aggressive biology, I suppose, is HER2 positive and TNBC. Okay.
Okay, so
what next will you do? You have a biopsy report, you have a mammogram, you have a PET CT. PET CT is showing that it is a non-metastatic disease, right?
Yes, sir.
Okay. So what is the final stage after investigation?
T2N1 disease, stage 2B disease.
Okay. And how will you
M0.
proceed for the management of this patient?
So for this patient, I would discuss in the multidisciplinary tumor board, and I would proceed with a neoadjuvant systemic treatment involving chemotherapy and dual anti-HER2 therapy, followed by breast conservation surgery and anti-HER2 therapy for 1 year, and adjuvant radiation to the breast.
So what exactly would be your chemotherapy regimen for NCT?
Sir, that PCHP regimen, sir. Pertuzumab, pertuzumab 840 milligram loading dose, trastuzumab 8 milligram per kilogram loading dose, and docetaxel at 75 milligram per meter square, and carboplatin AUC 5. So three weekly up to 6 cycles, and from second cycle the maintenance dose for pertuzumab will be 420 and trastuzumab will be 6 milligram per kilogram.
Any other alternative regimen can be given?
Sir, adriamycin cyclophosphamide followed by taxane and trastuzumab and pertuzumab.
Okay.
why do
Why
you
are you?
prefer the initial? Yeah. Yes,
Yes,
go
sir.
ahead,
Yes,
doctor.
sir. Yes, you go ahead. You go ahead.
No. Why do you prefer the regimen of TCHP over the anthracyclines? What is the basis? What are the reasons?
So at our institute we practice TCHP, and based on evidence, the results from Christine and Trifina trial, like there is a higher PCR with the TCHP regimen and less cardiotoxic as anthracycline is avoided.
Okay, so you want to avoid anthracycline because of the cardiotoxicity, or else is there anything relevant for a young lady?
So second malignancies, the risk of second malignancies.
Okay. Okay. Also, you'll be able to institute anti-HER2 therapy a little earlier compared to anthracycline-based regimen.
Yes.
So it was a study which has compared the anthracycline and non-anthracycline-based regimens. Okay.
The Trifina trial.
Yeah, that also had non-anthracycline. Otherwise, Train 2 trial is another trial which has compared these regimens.
Okay.
So what is the pathological CR you're expecting with this regimen?
Almost 50 to 60% fat CR.
Okay, all right.
Why do you want to add pertuzumab to this patient?
Sir, dual anti-HER2 blockade in the neoadjuvant setting has shown to increase the pathological complete response.
Okay. How is that going to help the patient?
Sir, she has an axillary node positivity, so there are chance being a high risk patient.
Are you giving NACT only for decreasing the size of tumor or for something else also?
Sir, for survival advantage.
Right. So what is is there survival advantage in terms of what is the survival advantage of adding pertuzumab?
The invasive disease-free survival.
Yes. So there is evidence that in node-positive disease, you at least increase invasive disease-free survival if you add pertuzumab. And obviously, as you said, there is increased chances of response, and so increase PATCR is also documented. PATCR for sure it increases. Disease-free survival is there at least till 7 years. Whether it will turn to OS benefit is a big question mark, and hence people are skeptical whether to add pertuzumab to everyone or you can avoid pertuzumab. So many UK NHS pertuzumab is not approved. Australia PBS does not approve pertuzumab to be given as NACT for this reason because OS advantage is still not proven.
Yes.
So with or without pertuzumab, both are acceptable regimens.
Okay.
Okay. Next. So you have started
So
with
how many
NACT.
cycles?
What all? Yeah. Yes, sir. Go ahead.
No. How many cycles you're planning, Dr. Ane?
Sir, TCHP for 6 cycles, followed by surgery and then adjuvant anti-HER2.
Okay. So, if the patient has no access to pertuzumab, what are the PAT-CR rates you are expecting?
Sir, for trastuzumab alone with the chemotherapy, it is around 30%.
Okay. All right. Okay.
And what all
So,
fitness do you assess before starting NACT?
So we assess the cardiac function of the patient with an echocardiogram.
Mhm.
Then the left ventricular ejection fraction is checked. If at baseline it should be at least around 50%. And we check the echo every three monthly during the neoadjuvant phase. And if there is a decrease in more than 10% from the baseline, then we have to temporarily stop the anti-HER2 therapy. And then we repeat the echo after 3 weeks. And if still it is less than 40%, like we have to start on an ACE inhibitor and refer to a cardiologist. If the patient goes in for a congestive heart failure, we have to permanently stop anti-HER2 therapy.
Supposedly, this patient is 50 years old and has history of ischemic heart disease. Stenting has already been done. Now the cardiologist is saying all coronaries are fine, but ejection fraction is 45%. You said you need 50%,
So I will still
and she has a
consider.
HER2 positive disease.
So
So what will you do?
I'll still consider anti-HER2 therapy, sir.
So when you said this LVF ejection is more than 50%, that is subject to other reasons also. So what
Yes,
is the
sir.
mechanism of toxicity for which one causes toxicity? For which drug are you worried about?
It's a trastuzumab.
And what is the mechanism?
Sir, it affects the cardiac myocytes, the neuroregulins in the myocytes.
So that is reversible. Somebody's
Yes, sir,
already pointed out.
it's
It is
reversible.
reversible.
It is
So
reversible.
we can take a risk. If coronaries are fine and patient is already has decreased ejection fraction, you can take a calculated risk according to what benefit that patient will have and add trastuzumab. Sir, you were asking something. I went on.
no. I mean, another thing is echo is always subjective. You better get a repeat echo, or you can rely on other more objective measures of ejection fraction when you find such a value in EF and you want to
Right, sir.
use trastuzumab.
Okay. So after how many cycles do you assess response, or you keep on giving 6 cycles, all 6 cycles? You would want to finish all 6 cycles, or you want to assess a response?
Sir, I will assess during every visit. I will clinically assess the patient.
Hmm.
Then, sir, if responding, I'll continue with the neoadjuvant treatment. And after neoadjuvant treatment, I will assess with an ultrasound imaging.
If somebody operates this patient upfront,
Yes, sir.
is he or she right, wrong? What will you say to counsel the patient? Patient has been operated upfront and was 3.5 centimeter tumor, and one node came out to be positive. Clinically, there was only one. Two nodes are there, so two nodes are positive. Giving NACT was must, or is it okay?
So, giving NACT was the best option. But however, as patient has completed the surgery, then we would proceed with an adjuvant systemic therapy.
Will your systemic therapy change?
No, sir. Like
Will you
adjuvant.
add pertuzumab?
So the advantage I am not sure, but still dual anti-HER2 can be considered.
Yes, in not positive, there may be some benefit. You are justified in adding pertuzumab, but the magnitude of benefit must be
Minimal.
is much lesser. And okay, so you wanted to do a mammogram ultrasound for this patient after chemotherapy. Is it really warranted? What is the purpose?
No, sir. Like to assess the response prior to
You can assess
clinical
clinically,
complete.
right?
Yes, sir. Yes, sir.
Yeah.
Clinical complete response can be assessed.
Okay. So what surgery you are planning for this patient?
So for this patient, breast conservation surgery will be planned, sir.
So what is the likely problem? Because if the patient goes into complete clinical response, what will you do?
Prior to the initiation of therapy, the tumor and the node should be surgically clipped.
Yes, you should coil it or clip it or mark it when if you're planning a BCT. Don't forget that.
Yes.
Okay. And how will you address the axilla?
Sir, in this case, I would go for the axillary lymph node dissection should be considered.
Okay. Okay.
So after NHCT, patient had a complete clinical response, and the surgeon operated, and there was no residual disease found either in the primary or in the a node. So what will you do further with this patient?
So I would complete adjuvant. I would complete the anti-HER2 therapy for 1 year with the trastuzumab and give adjuvant RT to the radiation to the breast.
Okay. And if there was a residual disease found,
If residual disease is found out, then I would consider a TDM1, sir.
for how many cycles?
Sir, for 14 cycles.
Why did you change your management? For what reasons? What will be the ultimate benefit of changing the therapy?
So based on this Catherine trial, actually there is a reduction in risk of invasive breast cancer by up to 50% with addition of adjuvant TDM1.
Somebody has pointed rightly. A paper has been published in NEGM recently. There is only 4.7 or 4.9% OS benefit. So overall survival benefit is there. DFS was very high, but OS ultimately turned out to be only 4.7 or 4.9 months. 4.9 at 4.9% benefit. Okay.
Okay.
So there is overall survival benefit roughly for all chemotherapy drugs that you add except for trastuzumab. There is a survival benefit of how much in a HER2 positive disease of adding anthracycline or taxane for a HER2 positive disease to overall survival. How much will you add percentage?
4%.
Right. So roughly 4.5% benefit is there. What is for trastuzumab? Anybody? It was initial trial showed 12%, 12% benefit.
At 10
Yes.
years.
Yes. Okay. So that was the drastic difference that had come. Now maybe TDXD will cause or none will cause that much difference in survival, adding that much percentage survival benefit.
So you said adjuvant RT. So what dose of RT you generally give?
For adjuvant RT, 40 grain 15 fraction to the residual breast tissue, along with a boost of 10 gray 5 fraction, and with the along with, also to the draining nodes.
50 or something lower?
The 40 grain 15 fractions.
Okay. Okay. All right.
Suppose this was a ERPR positive patient and HER2 negative with same
Yes, sir.
scenario, just a 3 centimeter node and a 3 centimeter primary and 1 node palpable. What would have been your approach?
I would consider a neoadjuvant Doston's chemotherapy.
She is just ERPR positive and 41 years old and only 1 node positive. 3 centimeter. So you want to give NSCT still?
Yes, sir.
Okay. Why? Clinically node okay, FNAC proven node 1 node positive. Still, you will want to give her NSAT, right?
Yes,
How
I
many
would
cycles?
consider. Sir, yeah, the Doston's chemo for eight cycles.
Okay. What is dose dense?
Sir, Doston's chemo is giving the same at shorter intervals. The same dose concentration is given.
And why is that? Why do you want to make it dose dense? The answer for most of the things that you do is some survival benefit. Okay.
What was the trial which addressed this question? I mean, at least.
The Doston's. The CalGB trial.
Yes. CalGB Alliance trial.
Went forward. Yeah. Okay. All right.
Anybody, people are of the opinion of not operating this patient upfront. And then why were they of the opinion that about the hypothetical case that I presented should be operated upfront? Why? ERPR positive, 3 centimeter, and only 1 node on all imaging. Do you agree with others? Somebody pointed in chat that operate upfront and then give adjuvant TC. So do you agree or you will still stick to your NACT plan?
So being a young patient, sir, neoadjuvant systemic therapy would be considered, sir.
Okay. A strong ERPR positive, young patient. You are also right, but maybe it is a strong ERPR positive grade 2 tumor, and it can be on with 3 centimeter. If it turns out with 3 centimeter, less than 3 centimeter, and a strong ERPR grade 2 positive tumor with only 1 node positive, you can offer this patient something. Which test do you think?
After surgery, if she's going for upfront surgery, then we can offer oncotype DX for this patient.
But it is she's premenopausal only if not negative, no? I mean, if it is premenopausal, it's in postmenopausal only.
It is.
It is approved
So dicey
for
situation. That is why I made premenopausal. Yes. Okay. But premenopausal, it is not much use of doing an oncotype DX.
Yes,
Okay.
exactly. So, and
if it
as
was
someone told, we can
postmenopausal,
de-escalate the chemo if we operate, and if it turns out to be early, we can avoid anthracyclines and just get away with 40C. So that is an advantage.
That would have been. There were two catches in that question, which sir also has pointed out. Okay. Postmenopausal, you can offer oncotype DX with confidence. Premenopausal, maybe not.
Okay, sir.
And Dr. Will you do genetic testing for this patient? Germline testing?
Yes, sir. So she's
why?
41 years of age, and so genetic testing is advised.
So what is the latest recommendation, ASCO recommendation on germline testing in breast cancer?
Sir, all patients diagnosed with breast cancer less than 50 years of age should undergo genetic testing, and in triple negative breast cancer less than 60 years of age, in male breast cancer.
So now it is 65, like up to 65, you need to, it is recommended to germline testing as per the ASCO SSO guidelines. If it is more than 65, then all the other factors come into play.
Okay, sir.
And especially if you're planning for PARP inhibitor therapy, such patients should have germline BRCA done. Okay. So how will you follow up this patient?
I would follow up this patient with every 3 monthly for the first 2 years, and 6 monthly thereafter up to 5 years, and after 5 years yearly. For every visit, I would elicit the history and clinically examine the patient, and I would consider yearly mammogram for this patient. And also, I would consider this as this patient has received anti-HER2 therapy every 6 monthly. I would consider echocardiogram for the first 2 years.
Okay. All right. So will you advise weight reduction for her during follow-up?
I would advise her to be physically active.
All right. So, Dr. Prabhat, any other questions?
No, none to this. Maybe something else. So, in what else situations will you add adjuvant olaparib? Somebody has asked in question, this is a HER2 positive, but we were discussing some hypothetical HER2 negative patient. So, to clear doubts, in what all situations will you add adjuvant olaparib?
That in BRCA positive patients.
The BRCA positive based on somatic mutation.
Sir, 1 year of adjuvant olaparib.
Based on somatic?
Based on germline mutation.
Yeah, BRCA based on germline mutation. Next.
Sir, in triple negative breast cancer.
Which triple negative cohort?
The BRCA positive. Germline BRCA positive.
More than 2 centimeter, clinically palpable, or no PAT-CR after NECT?
No PAT-CR after NECT.
Both of them.
Yes.
Okay. Yeah. Next, non-TNBC. Non-TNBC. Other indications for adjuvant olaparib.
Sir, in adjuvant. Sir, in HER2, in hormone receptor positive, HER2 negative, in germline BRCA mutated adjuvant olaparib.
Which one? Will you select or all? So more than 4 nodes positive. ER positive, more than 4 nodes positive. On those patients you can add.
Okay.
Only for the high risk patients.
High risk group.
Yes. Anything else, sir?
No, I think we have discussed all the relevant things, and she has presented it well. That's what I felt. Systematically.
Yeah, same here. Yeah.
Presented. So, Munir, should we discuss for some more time, or is there any?
Yes, sir. Yes, sir. We have time till 8:30.
Yeah.
It's 8.
Okay. Yeah.
15 minutes.
Okay. So let's discuss indications for adjuvant CDK4/6 inhibitors also.
Yes, please.
Where are you comfortable in adding adjuvant CDK4/6 inhibitor, in which scenario? Any?
Sir, adjuvant CDK4/6.
Rough guesses?
Yes, sir. Adjuvant CDK4/6 inhibitors can be added in patients with the hormone receptor positive disease with more than 4 nodes involvement in grade 3 tumors.
Okay.
Then certain stage 2A and B and then 3 disease.
So you said more than 4 nodes positive. So abemaciclib was added in patients who were more than 4 node positive.
4 node, yes, sir.
And
More than 4 node
in general,
positive.
People are more confident presently for more than 4 nodes positive. Less than 4 nodes positive, case to case basis, maybe you can add.
Yes, sir.
Then it will be ribociclib. Otherwise, it is abemaciclib. Okay.
Okay, sir.
Supposedly, this patient did not have PATCR. You gave TDM1, and later on, patient came back with you finished TDM1 3 months back. Now today, patient has presented to you with giddiness. You did an MRI, which is showing olig 1 met in the brain, 2 by 2 centimeter. What
Sir.
will you do next?
I will evaluate the patient with a PET-CT examination to rule out any other systemic disease.
Okay.
If no systemic disease, if
Great.
it's an isolated mets, I would go for a resection followed by an SBRT. And I would
Okay.
proceed with a systemic treatment to target the target the brain lesion with the lapatinib. Other agents are tucatinib.
What will be your preferred regimen? So I agree with you with surgery, if possible, it is very isolated. I agree with adjuvant RT. Now, how will you treat this patient systemically, or you will not treat systemically?
I would treat systemically.
Okay. Okay. With which regimen? Patient has come back within 3 months after completing the TDM1.
So the options are lapatinib, capecitabine, tucatinib, lapatinib and capecitabine, TDXT.
So lapatinib and tucatinib are not combined together. First option is just say number wise. What are the options available? First option is
Yes, sir. Lapatinib, capecitabine.
okay.
Okay, practically that's the first option. You can
Yes, sir.
order them based on the benefit.
Yes, sir.
Next.
Okay. Other options?
Tucatinib with capecitabine.
And
No,
Okay.
there is a catch in that. How was tucatinib given? It is added to trastuzumab also.
Yes,
Gave
sir.
trust to tucatinib. They were smart enough.
Trasto with
They
tucatinib. Yes, sir.
Yeah. So answer should have been traced. Gave trust to tucatinib.
Yes,
That is
sir.
second option. Third
Yes, sir.
option
So third option is Enhertu.
and HER2. Okay. Which one will you? If the patient has no constant, what would have been your first choice?
Enhertu, sir.
Okay. Why?
As based on the Destiny breast trial in
Okay. No, chalo, that will be too much. Okay. I agree with
yes.
you. The TDXD. But now question comes for what duration? It was an oligometastatic disease or a metastatic disease? What do you think?
It is an oligometastatic recurrence.
So till what time would you like to give? Like to
Until,
give. I'm not saying what is the evidence.
until progression.
You would want to give up till progression. Okay. Okay. So there is no one answer, so I agree with you. If you want to give it, and if somebody says wants to give for 1 year, maybe that is also right. If you are saying that it is a oligometastatic disease, you have treated the secondary site and given even RT also.
Yes, sir.
Do you agree, sir? Or you have some
Yes,
point on
I
this?
agree. I mean, that's a tough call.
The
So, I
tough
mean,
call.
we'll have to individualize and make the decision. So, some questions are there. So, Annie, can you write the order for whatever regimen you're planning? Maybe TCHP.
Yes, sir.
So, what are things will you give? Doses you have mentioned.
Yes, sir.
Other than that,
Yes, sir. No, so I pre-medicate the patient with the dexamethasone, 20 milligram IV, injection phenyramine maleate, 22.7 milligram IV, and injection PPI pantoprazole 40 milligram IV. Then injection pertuzumab 840 milligram, loading dose in 250 ml normal saline. Loading dose I'll be give the infusion over 60 minutes, and injection followed by injection trastuzumab 8 milligram per kilogram loading dose, infusion over 90 minutes. Then injection docetaxel 75 milligram per meter square in 250 to 500 ml normal saline over 90 minutes, and injection carboplatin area under curve 5 into 50 to 500 ml, 5% dextrose over 1 hour. So then,
Excel 1 hour is enough, no? I do want to give for 90 minutes. And
docetaxel 1 hour. 1 hour.
And
1 hour, sir.
antihistamines are required?
Sir, trastuzumab and pertuzumab is given, so
it's not. Trastuzumab doesn't require antihistamines for all the patients. Is it
For
your practice?
which drug among the four? For which drug among the four do you require Avil for this patient?
docetaxel.
Carboplatin does not require.
Yes, sir.
And why did you say for docetaxel?
Sir, infusion reactions.
Does dosi cause? Yes, even dosi causes, but dexa is okay for that. Carboplatin mainly we will give Avil.
Okay,
Right?
sir.
Not for Trastupertu. Trastupertu, no pre-medications are given when patient is on maintenance Trastupertu, unless patient had an allergic reaction in one of the previous cycles.
Okay, sir.
So what are the side effects expected with each of the four drugs that you planned as NCT for this patient?
Yes, sir, for the trastuzumab and pertuzumab.
Each drug. Go each
yes,
drug wise.
Okay, sir. So for pertuzumab, rash and diarrhea are the most common side effects. Cardiotoxicity. Then for trastuzumab, cardiotoxicity. Then sir, bone marrow suppression, alteration in the liver enzymes. Then for
With? This is for which drug?
sir, for trastuzumab.
Trastuzumab, do you repeat CBC during maintenance?
No,
Trastuzumab?
sir. No, sir.
If there is myelosuppression, do you think that would have been your way your hospital treats? Right. If we don't do CBC, that means there would
Yes,
have
sir.
been no myelosuppression. That is why you don't do it in the maintenance
Okay,
setting.
sir.
Right?
Yes, sir. For docetaxel, myelosuppression, peripheral neuropathy, sir, edema.
What is that called? A more better term for that would be?
Sir, fluid retention.
Fluid retention.
Info, sir, carboplatin, nephrotoxicity, bone marrow suppression.
What are you more worried among the myelosuppression with carboplatin?
Thrombocytopenia, sir.
And nausea was nowhere in your side effects.
Yes, sir.
That should have been your first answer for
Yes,
any
sir.
side effect if somebody asks you a side effect, right?
Yes, sir. Highly evident.
Okay. So be thorough with the chemotherapy prescriptions. Many a time we just follow the template. So when you ask to write, many people will struggle. So be thorough with the chemotherapy prescriptions.
A dose of anthracycline and cyclophosphamide and side effects.
Sir, anthracycline dose is 60 milligram per meter square, and cyclophosphamide dose is 600 milligram per meter square. And the side effect of anthracycline is cardiotoxicity, myelosuppression, nausea, vomiting. Then, sir, for cyclophosphamide, alopecia, yes, sir.
Leukocytis.
Mucositis.
Sir,
Cyclophosphamide.
for cyclophosphamide, bone marrow suppression, then nausea, vomiting.
Okay. Hyponatremia. Side effects of TDM1.
Side effects of TDM1 is vomiting is the most common side effect. Then, sir, then pneumonitis.
They're going to rare side effects. Common.
Bone marrow suppression,
Yes.
Yeah, thrombocytopenia
then cardiotoxicity,
and
infusion
cardiotoxicity.
reaction.
This should have been your first two answers. Thrombocytopenia and cardiotoxicity.
Cardiotoxicity.
So mechanism of action of TDM1 and TDXD. And what is the difference between the two drugs?
Sir, TDM1 is an antibody drug conjugate. The DM1 is the emtansine is the chemo moiety, and upon binding to the um, upon binding to the receptor and internalization, there is lysosomal degradation, then followed by disruption of the microtubular network causing apoptosis.
And
Therefore,
other mechanisms of TDM1?
the antibody-dependent cellular cytotoxicity.
Okay. Difference with TDXD?
TDXT is it's also an antibody drug conjugate. Then topoisomerase 1 inhibitor. It's receptor-mediated internalization and lysosomal degradation, and then inhibition of the downstream signaling pathways and also there is bystander effect in TDXT.
So this is very good. Somebody types and then you can read it easily. That was first thing that you should have. What is the difference between the two?
Sir, there is a cleavable and non-cleavable linker.
That is one difference. Difference between
Then,
the amount of payload.
Sir, in TDM1 it is 1:4, and in TDXT it is 1:8.
And the drug itself is different, and mechanism of the payload is different. Okay.
Yes.
So be ready with a few definite points for each drug. All this anti-HER2 difference between the mechanism of action is a favorite question. So be ready with the clear answers for all these drugs.
What new therapies beyond TDXD are you aware of in HER2 positive breast cancer? Besides the three drugs, trastuzumab, TDM1, and TDXD.
Margetuximab.
Full name?
I'm not sure.
Okay. Second, other?
Saxituzumab govitecan.
Is it for HER2?
No, so it is to TNBC.
It is antibody against what?
Top two antibody.
It is anti-TROP2 antibody.
Yes, sir.
Right? Next HER2?
Neratinib.
Neratinib is what?
So it's a TKI.
It's a TKI. How does the mechanism of a TKI differ from an antibody?
Sir, neratinib binds to HER2 1 and 3.
A TKI and antibody. What is a TKI? Why is it called TKI? And why is it
It binds to
trastuzumab called an antibody?
it binds to the tyrosine kinase.
So TKI is tyrosine kinase inhibitor. What is
Yes,
tyrosine
sir.
kinase here?
So it is the intracellular the intracellular domain in the
of the receptor, and the antibody binds to the extracellular receptor of the extracellular domain of the receptor.
extracellular ligand binding domain.
Okay. And you will have to be aware of the difference between all the TKIs. TDM1 and TDXD, you are aware. The difference between lapatinib, tucatinib, neratinib, even I am not aware, but I think you should be aware. Are you aware? Any chance?
That's all I know.
That's it, sir, from my side.
Yes, I think we can wind up. Munir?
Yes, I think Dr. Annie had done well. Any closing
you, sir.
remarks from examiners?
No, as I've already mentioned, she has presented it well in an organized way. So all the questions related to the case were answered properly. Then other things are mainly theoretical discussions and hypothetical situations. And certain things be very, very clear, like there are certain frequently asked questions. So be ready with the answer so that you can answer them quickly and clearly. That's it. Dr. Prabhat may be able to add more because...
I think she was quite calm during the exam, so that I liked. Very calmly and patiently, she was giving her answers, and obviously she was thorough with the case. For hypothetical case, also she gave accurate answers. What how will she manage? And there can be multiple ways of managing a patient. You only have to be confident the way you are saying it. Not overconfident, but you have to be confident, and she was. In spite of people writing adjuvant chemotherapy and others for the TRPR positive, she was confident that she wants to go the way of in NACT. So I liked it.
Thank you, sir.
I think we can close the session. So thank you all. Thank you
Okay.
all the
Thank you.
participants.
Thank you.
Thank you, sir. Thank you.